Hello everyone, and a very warm welcome to today's webinar where we are exploring the future of the hearing healthcare. Hearing clinics are facing increased pressure. Increased pressure due to demographic changes and growing societal demands, leading to longer waiting times for diagnostics and access to appropriate hearing support. How can we address this bottleneck, and what role can remote diagnostics and self-testing play in the future of hearing healthcare? That's what we are trying to explore here today. My name is Jeppe Lindegaard. I'm head of branding, strategy and events here at Danish Sound Cluster, where we aim to unite sound people, to ignite collaborations and curate inspiration across the audio, acoustics and hearing industry. Now, please welcome today's panel. We have Henrik Jacobsen, MD, mBA, and head of the Department of Audiology at Aalborg University Hospital. A warm welcome to you, Henrik. And we have Lene Dahl Siggaard, who's MD, PhD, MBA at the University of Southern Denmark and clinical lecturer. Welcome to you, Lene. And we have Lena Schell-Majoor, postdoc researcher and science manager in the Cluster of Excellence Hearing for All at the University of Oldenburg. Thank you for joining us, Lena, today. And we have Jesper Hvass Schmidt, professor, senior consultant, MD, PhD at the University of Southern Denmark. Welcome to you as well, Jesper. And finally, we have Dorte Hammershøi, who's professor at Aalborg University, and she will be moderating today's Q&A section. Dorte, you can turn on your camera, please. Thank you. She will be moderating the Q&A session today, where you are very welcome to ask all your questions in the Q&A box, and Dorte will take care of them in the end there. But Henrik, Lena, and Jesper will first be doing the individual presentations. So please kick back and enjoy your morning coffee and listen first to Henrik Jacobsen. Thank you very much.
Thank you very much. I suppose I have shared my screen. Is that correct?
Yes, that is correct. Looks good.
Perfect. So let me start with a patient. An elderly man in his late 70s comes to his general practitioner, not because of a hearing loss, but because he's worried. He has become quieter, less engaged. He avoids conversations and he withdraws. And the concern becomes, is this a cognitive decline? Is it depression? Or is it something else? But the explanation may be much simpler. What if he just cannot hear well enough to stay connected? Now imagine what happens next. He enters the system, he is referred, and then he waits. Weeks, months, sometimes even years. First for assessment, and then even longer for treatment. And during that time, nothing improves. The isolation continues, the functional decline continues, because in hearing healthcare, delays are not without consequences. And this is not an isolated case. We are facing a demographic shift, more elderly patients, more hearing loss, and at the same time, limited capacity. So the question is not whether the system works. The question is our current system ready for the future? Is it sustainable? Can it scale? Should it scale? Can it deliver treatment in time? Thank you for this invitation. Today, Lena and I would like to talk about the future of hearing healthcare and why we have challenged the existing pathways and the healthcare professionals, which, by the way, is ourselves. We have designed and tested a blueprint model within the hearing healthcare area, but we believe that it can be used across the healthcare system in general. we have tried to move from fragmented pathways to something more coherent, more efficient, and more patient-centered. My name is Henrik Jacobsen. I'm the head of the ENT and Audiology department here at Aalborg University Hospital. And what we will present today is not just a technological solution, but it's a broader healthcare challenge and how we have approached it. This article from 2021 illustrates by this figure an age-related hearing loss as being associated with both cognitive impairment and late life depression. Importantly, the authors emphasize that this relationship is probably not explained by a single mechanism, but rather by several interacting pathways. On the cognitive side, one proposed explanation is increased cognitive load. When the auditory input is degraded, the brain must use more effort simply to decode the speech. This means fewer cognitive resources remain available for memory, attention, and executive function. A second pathway is social isolation. People with hearing loss often withdraw from conversations and social activity because communication becomes effortful, frustrating, and sometimes embarrassing. Reduced social engagement is in itself associated with a cognitive decline, but also with depression. A third possible mechanism is structural brain change. Studies have shown that hearing loss is associated with change in the brain volume, particularly in the temporal region involving the auditory processing, but possibly also more broadly in regions relevant for memory and emotional regulation. The article also points out that some mechanisms may be shared rather than causal. So the key message here is that hearing loss may contribute to both cognitive impairment and depression through overlapping and mutual reinforcing pathways. And because age-related hearing loss is both highly prevalent and substantially underrated, it may represent one of the most relevant targets if we want to reduce a broader late life morbidity. Hearing loss is strongly associated with age. As you can see here, the prevalence increases dramatically in older age group. Hopefully, we will all reach 85 years. And as you can see, if we do that, 50% of us will face a moderate or high-grade hearing loss. This means that hearing loss is not a marginal issue, it is a growing population-level society challenge. But importantly, it is a predictable one. When we overlap that with the population data from Denmark, the implications become even clearer. This is the population distribution in Denmark at 2020, and the apple-shaped figure indicates that we are moving towards an older population structure and at the same time not enough younger generations to take care of the elderly. We are facing an increasing demand not only for hearing aids, but for assessment, diagnostic, and follow-up. This means more demand and relatively less capacity. If we do not change how we work, we will not be able to deliver healthcare in the future. Our current system is fragmented. Patients move between sectors, and pathways are not always clearly defined. This leads to repetition of investigations, variation, and inefficiency. What we need is structure. Our need for change is driven by demographic pressure and increased political attention. There is a clear ambition to create a simpler and more efficient system. But there's always a concern. Will the efficiency compromise quality? And that is exactly the challenge that we have addressed. together with private and public healthcare auditory clinics, the Danish Health Data Authority, and the Danish Health Authority, we have developed and tested a more streamlined model. Fewer visits, fewer tests, better overview, more targeted care, and importantly, this is not a political solution, it is a scientifically tested solution. Lene will present those results shortly after this presentation. So when we talk about the future, the reality is clear. There will be more patients, greater need, limited capacity. We must redesign the pathways. And we must be evidence-based. It must be safe. It must work for the patient. And if we succeed, we can establish a system that is better for the patient, better for our society, more efficient and sustainable. And that is exactly what we are trying to implement in the Danish healthcare system. We are trying to future-proof sustainable healthcare. Thank you. And I'll switch over to Lene.
Thank you very much, Henrik. Now I believe you need to share. Yes. And Lene, if you can please share your screen. And unmute your microphone, I believe.
Mute. Can you hear me?
Yes, perfect. Thank you.
And I hope you can see my slideshow. Yes, good. Thank you so much for the introduction, Henrik. We're sitting in the same room, but with each our own screen. And thank you, Jeppe, and everyone for the opportunity to share the story of the digital referral model in Danish hearing healthcare. My name is Lene. I'm an ENT specialist. I'm head of research and innovation at the ENT department here at Aalborg University Hospital in Denmark, working very closely with Henrik and have been doing so over the past 5 to 6 years. I've structured my talk in 3 parts. First, I want to give you some background on the work that preceded the InHear project. Then I want to talk about the key aims and key findings of the InHear project itself, where we developed and scientifically tested a digital referral model in a randomized controlled trial. And finally, I want to talk about some of the present blueprints and the future perspectives, because the work has been going on ever since the InHear project ended. And the model has now received both financial and political backing for a national implementation in Denmark. My knowledge in this area is grounded on previous work. I did my PhD thesis centered on the InHear project. I co-wrote with Henrik and other colleagues a comprehensive report to the Council of Health Directors at Danish regions covering implementation benefits, challenges, and recommendations. And I did my mBA thesis covering challenges in hearing healthcare today and ways to solve them. Okay, so to talk about some background, the story of the digital referral model began well before the InHear project even started. The idea actually originated with, in my mind, or in my objective, and very innovatively minded leader in the hearing aid industry who drew inspiration from dermatology, where the digital referral model or remote referral for skin conditions was already being explored at that time. This person was also instrumental in establishing the working group for the future of hearing rehabilitation. This group is a cross-sector group bringing together private and public stakeholders from the industry, from the suppliers, the professional societies, the regulatory body. We have the GTS Institute for Technology, the patient unions, the hospitals, the universities. And in 2015, this group of people published a vision paper setting out some very ambitious objectives to elevate Denmark and Danish hearing healthcare to a global standard, with a particular focus on establishing Denmark as a leader in hearing research and innovation. And then in 2018, the Danish Ministry of Health launched the Future of Hearing Initiative, also known as a hearing program to strengthen the hearing sector. For the international participants, I'm sorry, this is in Danish, but this is the official side of the program, the hearing program. And this program introduced 6 specific initiatives to ensure a high quality, equitable hearing care across both public and private providers. And the very first initiative involved the development and testing of a digital referral model. So in 2020, we, Henrik and our research group and I in the North Denmark region, began planning the InHear project, the Innovation of Hearing Rehabilitation and Effects of Reform project, in partnership with the Danish Health Data Authority, which was a direct response to that first initiative in the hearing program. And since then, we have published 4 papers, manuscripts from the project documenting our work in the project. So the InHear project itself, centered around published in my PhD thesis, we ambitioned, as Henrik said, to simplify what had become a very complex patient journey, a journey involving multiple physical visits, repeated hearing tests, and significant risk of waiting time alongside the journey. And also where physical ENT specialist assessments are and were obligatory prior to hearing aid treatment. We wanted to explore whether we could deliver high-quality diagnostics and treatment planning from a single audiological assessment, getting patients from the referral to the treatment faster and with fewer in-person visits. And this model has 2 core elements. The first is visualized in visit number 1, a standardized examination conducted by an authorized audiology assistant, producing a very structured data package for the digital referral. And secondly, an asynchronous digital assessment, diagnosis, and referral decision made by ENT specialists performing these digital referrals independently of time and location, allowing for the most patients to have their hearing aid fitted potentially by visit number 2. And the primary aims of the InHear project was to investigate, firstly, will this model compromise patient safety? Meaning, will we risk overlooking patients with the complex hearing loss cases or targeted ear diseases that need specialized care or even surgery with this digital referral setting? And secondly, will digital referral compromise the patient-experienced treatment effect and satisfaction? So we randomized 751 potential first-time hearing aid users in a 2-to-1 ratio, digital referral versus the existing model of physical referral by private ENT specialists. And then patients were referred to one of 3 pathways: no treatment for those with normal hearing, direct hearing aid fitting for those with simple or uncomplicated hearing loss cases, and thirdly, a specialist assessment at a public audiology department for those with complex hearing losses or targeted ear diseases. And then 3 to 4 months after enrollment, all participants attended a gold standard assessment, which was a 30-minute consultation with a medical audiologist or an ear surgeon who independently categorized each patient in the same 3 categories. And also, throughout the study, patients completed questionnaires on their perceived treatment outcomes and satisfaction. Now, just to say a few words about the standardized examination, it had 3 components. Firstly, a structured patient questionnaire adapted from an already validated instrument called Sidra, which screens for targeted ear diseases. It was supplemented by the tinnitus handicap inventory for those participants who reported having tinnitus. Secondly, we performed a full audiometry, including air and bone conduction, speech audiometry, tympanometry, and acoustic reflexes. And thirdly, we did a video otoscopy with still images of the eardrums. And our main result, not all of it, but this is the main result, showed that when we compared both groups against the gold standard, the digital referral group was actually referred with significantly higher accuracy than the physical referral group. And furthermore, our questionnaire data showed that there were no difference between the groups in perceived treatment effect and satisfaction. They were equally very high. So the conclusions were pretty clear. We thought digital referral did not compromise patient safety in the setup, and it did not compromise the patient experienced treatment effect and treatment satisfaction. Now, for the present blueprints, following the InHere project, we, Henrik and I, and some of our colleagues were invited to present our findings to the Council of Health Directors at Danish regions. And this is where the report comes in. We hypothesized that digital referral could streamline the patient pathway and address some of these key challenges that the sector faces today. And as you can see on this slide, giving fewer physical visits and hearing tests, more transparency for the patient, more cost effectiveness, reduced waiting time, unbiased visitations by ENTs, higher data quality, data sharing opportunities, and better resource allocation. And as a result, and partly as a result of this visit with the health directors, a cross-regional steering committee was established with the mandate to firstly map the benefits and challenges of a national rollout and to design a supporting digital infrastructure. Second, to pilot the model across all 5 regions. And thirdly, to develop concrete implementation recommendations. And we had many assignments, but one of the very most important tasks for the steering committee was to map the patient's digital journey in full, defining a complete workflow for the patient and the supporting technical infrastructure. And as you can see, this is the original blueprint. It was very detailed, and I'll spare you a full walkthrough. But in simpler terms, the workflow resulted in a description of a comprehensive digital ecosystem drawing on both existing and yet to be built national digital solutions. And with this workflow well defined and mapped out, we were able to identify where each task sat and with whom, and how we intended to address it, both structurally, professionally, and technically. One of the new components was a national digital hearing folder, and combined with a new cross-regional referral system to be integrated with the existing national health portal called Sundhed.dk, the audiological management systems used in both private and public sectors, and also the national referral infrastructure. Now, for the future, we turned in our report to Danish regions in June 2025, and shortly after, the project reached a significant organizational milestone when Danish regions formally decided to implement digital referral in hearing healthcare nationally. And I'm showing an official Danish quote from the Danish region's financial agreement from 2026, stating their political backing. I'm sorry that you can't read it for the international viewers. But the implementation process is now well underway, and it's building on both the scientific evidence from the InHere project and the extensive organizational groundwork that we laid in the steering committee and the contents of our report. And for the final slide for me, future perspectives and looking ahead, I do see digital referral as one component of a more broader ecosystem of innovation in the Danish hearing healthcare system, including possibly user-administered hearing tests, of which Jesper will tell you more about shortly, and also the possibility for automated decision support tools. And I think together that these developments point toward a future where the journey from hearing difficulty to treatment is much faster and is safe and more accessible for patients and also providers alike. Yes, that was all for me.
Thank you very much, Lene, for your very insightful presentation. Now I would like to leave the floor to Lena Schell-Majoor. Lena, you can share your screen. And unmute your microphone if you haven't already.
Yeah. So I think you can hear me and you see my presentation. Is that okay?
Yes, it looks good. Thank you.
Great. Okay. Yeah. So thank you also from my side for giving me the opportunity to talk a little bit of on our work of self-administered and remote hearing assessment, which we are doing mainly in the context of in individualizing hearing healthcare in the future. So my slide is not, here we go. I will talk very shortly about the situation in Germany, as I was asked to give some basic information on how hearing aid provision is dealt with in Germany. Then I will say a few words on the general idea, or especially the topics related to the remote and self-administered hearing assessments in the Hearing for All project. The virtual hearing clinic will be introduced, which is kind of a tool that was developed in Hearing for All. I will give some examples of our remote and self-administered hearing assessments and the work we have been doing on that. And then I will wrap up with some conclusions and an outlook on our next steps. So in Germany, you can basically get hearing aids where the costs are covered by the health insurance if they are prescribed by usually an ENT doctor, and you have to fulfill certain kind of diagnostic requirements in order to be eligible for this prescription. So you have to have hearing thresholds of at least 30 dB at one frequency between 500 Hertz and 4 kilohertz. And you have to have a maximum speech intelligibility of 80% at 65 dB measured with the Freiburg monosyllabic speech test. So that is a speech test where you present single words and you measure how many words have been understood. And so if you get a prescription for a hearing aid, there are also some guidelines on what the hearing aids should feature. So you get digital hearing aids with multi-channel signal processing, feedback suppression, and noise cancellation. And they also have to offer a few different programs that you can switch between. So these are basically quite okay-ish hearing aids. But of course, you have to pay additionally if you want to have extra features. For example, connectivity like Bluetooth connections, or more advanced, maybe AI-based algorithms, for example, for feedback suppression or noise cancellation. So the situation is not that bad, let's say, and we see quite a good hearing aid uptake in Germany. However, we also see that we are facing quite some problems. So one, of course, is the quite a large variation in benefit for individuals. And of course, also we are facing shortages of health professionals in the German system as well. So it's always kind of an economic pressure to fasten processes, make them like easier, or kind of source them out to the patient themselves. And that is a bit where the Cluster of Excellence Hearing for All is stepping in. So that is a kind of a large German funding scheme, these Cluster of Excellences, and Hearing for All is one of them, which is obviously dealing with hearing. And it has been running for two funding periods already. And in January, the third funding period started. These are the objectives of this new funding period. It's a very broad, multi-perspective research on hearing. But the objectives that are mostly related to the self-testing or remote testing parts is Objective 2, where the aim is to advance auditory phenotyping, so make precise characterizations of hearing abilities. And for that, the aim is to link data from different sources, so clinical data, lab-based data, and also remotely collected data, to be able to derive a more targeted treatment recommendation. And then Objective 3 is developing an open data space for audiology, where the main aim is to create larger data sets to be able to employ data-driven approaches in audiology. And I think Lene has already given some examples where that could be interesting. So that are maybe the two aims that are closely related to the topic for today. The tool that we are using in the Cluster of Excellence for this self-testing, or for this remote and self-administered assessments of hearing abilities, is the so-called virtual hearing clinic. And it's basically a modular platform that is browser-based, and it does not only cover self-testing, but also different aspects. So the idea is to use results from self-diagnostics to derive auditory profiles and classify people into these profiles, and then use the profiling to give them a treatment recommendation, and also give them an idea of what the potential benefit from, for example, hearing aid usage could be. And we were also working on enabling users to be able to adjust the settings of their hearing aid by themselves. So methods and interfaces that are connected to that. So the thing for today is, of course, the self-diagnostical part. And here we are mainly going down two pathways. So on the one hand, the idea is to offer low threshold hearing diagnostics for individuals. So people don't have to go anywhere. They can mainly take out their mobile device and do the testing on their own. And the idea here is that we can raise earlier awareness for hearing losses and maybe awareness for mild hearing loss, so beginning hearing losses, and also increase patient empowerment so that people are actually put in the position to take responsibility for their own hearing healthcare journey by being informed about maybe their own hearing preferences, but also their own hearing abilities. And then the second pathway is the idea that we use the virtual hearing clinic as a research platform. So we want to collect larger and more diverse data sets, as the data sets we usually deal with, especially in research, are rather small and also pretty biased, as people that are showing up for our studies usually don't have any problems with mobility, for example. So it's really not a good representation of the whole population. And the idea is that based on more information on the individual and also the informed individual and these larger data sets, we can increase the ultimate benefit through individualizing the treatment and making more targeted treatment recommendations. So when we are talking about these remote and self-administered measurements, so we have been working on that for quite some years now. The idea is basically to transfer, adapt, and enhance more or less established diagnostic methods and kind of employ them for remote and self-administered usage. However, that of course comes with several challenges. One is, of course, that people are using their individual equipment, so we don't have calibration, and we have different equipment. There might be background noise as people are not sitting in a soundproof booth anymore. And we also might have problems due to decreased attention and motivation. So if you don't have a professional standing on the other side of the door, kind of looking on your fingers, you might kind of be a bit slacky with the measurements, and that can also actually influence the results. So we have been working on all of these challenges and try to find ways to deal with them. And I want to give some examples on what we have come up with or where we stand so far. So one measurement that we have been investigating a lot is the speech and noise audiometry. So it's the so-called matrix sentence test. And maybe for those of you who are not so familiar with that, the basic idea here is that you present sentences in a background noise, and these sentences are drawn from this matrix. So you have a matrix with 5 word categories and 10 representations of each word category. And you present a background noise, usually with a fixed level, and then you vary the level of the speech, so different sentences. And then you measure the so-called speech reception threshold, which is the signal to noise ratio, where people or the individual understands 50% of the speech. This is all in German, but this is what the interface looks like in the virtual hearing clinic. And we have also been investigating different types of interfaces, especially for smartphone usage, as you have a very limited screen size in this case. So comparing the results for this speech reception thresholds measured with the matrix sentence test in the lab versus with the virtual hearing clinic, we generally see that there's quite good alignment. So we get very similar results measuring with the virtual hearing clinic compared to measuring in the lab. And we also see that we have a good retest reliability of this virtual hearing clinic measurement. So measuring twice with the virtual hearing clinic delivers very similar results as well. And we have also employed this matrix sentence test in an international large online study. So here we implemented the matrix sentence test with different languages. So it is available in different languages. And it's quite a lot of data here, but the main point is that this blocky markers here represent data from literature, which is also lab-based data. And the other 3 points, which are a bit lighter, also represent our online data. And you see that in the literature data, we have differences in these average speech reception thresholds between the different languages, which is simply due to the characteristics of the language. And we see that our online data reproduces these differences quite well. And that is really a nice finding, even though we also see we have quite an increase in the variance in the data. So our general takeaway for the metric sentence test is that it really produces reliable and valid results. We have larger variances. And one reason why we kind of started with the speech and noise measurement is that as you are measuring the signal to noise ratio, where people understand 50%, you are not so much depending on the absolute levels. So it's rather important that you know the exact signal to noise ratio, but if you're really measuring, for example, at 65 dB and 60 dB, or if it's 67 and 62, it's not that important. So that works really well. And another thing we are doing is that we are working on optimizing procedures for the self-administered and remote measurements. And this is an example where Chen Tzu has been working on. So it's the so-called adaptive categorical loudness scaling measurement, which basically measures the loudness perception of people, so throughout the entire dynamic range. And the original measurement contains 2 phases, phase 1 and phase 2. And the basic paradigm is that you are presented with a sound, and then you have to indicate, again, this is German, but you have to indicate how loud you perceive the sound, from not heard, very quiet, to very loud and too loud. And there are several steps in between. And from these data, you usually derive so-called loudness growth functions, which tell you something about the dynamic range and how loudness perception is distributed in this dynamic range. And what we did here is that we added a third measurement phase presenting stimuli quite near to the threshold, because the idea is that with one measurement paradigm, we do not only get information on loudness perception, but also a good estimation of the hearing threshold. So what you usually measure with an audiogram. And of course, the challenge here, especially when compared to the speech and noise, is that you are much more depending on some knowledge about the absolute level presentations. And there comes these loudness growth functions into the game. So here you see different loudness growth functions, so for different frequencies, and each loudness growth functions represent a certain hearing loss. And you see that the function changes the shape. So it's not only shifted throughout this parameter space, but it changes the shape. And therefore, the idea is that by measuring the loudness growth function, we can also estimate the calibration offset for the specific device. For example, by using this lower slope here or the upper slope, so you can derive different parameters from that. So that is one approach to deal with this lack of calibration and the differences in equipments. And I know this is, if you're not familiar with all this, it's quite complicated. I'm happy to answer questions afterwards, but I just wanted to give you some impression of what our work is actually and what we're actually doing in our work. So wrapping up, I hope I could show that we saw that remote audiological measurements, so here really picturing the situation of someone being somewhere using their individual equipment, that it's generally feasible, but you have to verify the feasibility for each method again. So you can rather not use any measurement and simply just deploy it on a smartphone, but you have to be a bit cautious of, so how is the measurement paradigm? Do people understand what they have to do, and so on? And of course, the idea is not to replace clinical measurements or lab-based measurements, but we rather see a valuable data addition or data enhancement that we can use, for example, for big data approaches in audiology, or it's usually big data because compared to real big data, it's still small data, but yeah, larger data maybe. And so what we are keeping on doing is we are continuously verifying and integrating further measurement modules to enable a broad characterization of hearing abilities. We are working on this issue of lacking calibration so that we can actually, in not too long from today, be able to connect data from different sources, and among that use remotely measured data to work on advancing the auditory profiling mechanisms so that we can then derive individualized targeted treatment recommendations for people having a quite good characterized hearing loss. And with that, I would like to thank you and the colleagues that have been working on that, and I'm happy to answer questions after the last talk. So looking forward to the discussion.
Thank you very much, Lena. And now you can unshare. Thank you. And I'm just going to do like this, because for those of you who have joined us late, here's a look at our great panel of experts today. And now we're just missing one presentation before we head over to the Q&A. There's already a couple of questions coming in. Thank you very much for that. So with that, I would like to say, please take it away, Jesper.
Yes, thank you. Just to share. We should be able to see my screen here. Okay, and I should also use this opportunity to thank you for the invitation to do this little talk about what we have looked into by implementing user-operated audiometry system, and what this potentially could add to our clinical system today. Henrik and Lene also already pointed out some of the challenges that we see here, at least in the Danish system, with facing waiting lists. We are facing waiting lists for a lot of patients, so we have a demand on our capacity here, and a lot of patients will have to wait for a long time to get the hearing aids. So we have for instance, one patient here coming to get her hearing aids, and she might have been waiting for quite a long time to get to the phase where she's actually presented for the hearing aids. To get there, she will, at least in the Danish system so far, she will face that she has a problem, and then she can step into one of those shops that are all around the country and the cities, and they have her hearing measured there. And they will very well tell her that she's probably got a hearing loss, but what happens next is that she will have to have that hearing loss verified by an ENT doctor. And this ENT doctor say, yes, there might be a hearing loss, and so she can get back to the clinic and get her hearing aid, or she could go to the public clinic again. So that means that there will be a lot of steps here, and that also requires a multiple testing of hearing at each steps, because there could be a delay. In some cases, this delay could be up to a year for instance, from the referral from the ENT doctor to the public clinic. So you can also get directly to the ENT doctor and to the public clinic like that. But still, this will be challenged by a lot of waiting before you actually can get your hearing aids. So we have actually a queue in Denmark at the moment, at least in the public clinics, to get the hearing aids. That's why what motivated us to see, can we do things a little bit differently, and why, if patients measure the hearing themselves, could it actually free up some capacity? Because if the audiologists do not need to do the testing, then they could fit hearing aids instead. So that's actually the motivation of what we have been looking into. So I've been working on this area for quite some time, working with various systems of user-operated audiometry. And as pointed out by Lena before, of course, it's an issue with background noise, but it's actually quite limited if you have a proper headsets for doing this. Then you would actually minimize the influence of the background noise quite substantially. but of course you cannot eliminate it. But working with an user-operated system where the patient advances the tests in their own speed, it also helps because usually background noise would be some fluctuating noise that occasionally actually occurs, and in this case you actually will be able to advance the test when it's quiet, if it's something that you actually notice. So we also asked the patients about what their thoughts were about the user-operated audiometry before we actually started the project, and we also asked the professionals what are their thoughts. The patients were generally quite happy about it. They thought this was a nice idea, and they were willing to do so. Of course, we could probably have expected that. Some of our professional colleagues were a bit reluctant about introducing such a system because they have a lot of they had a lot of thoughts about what could actually be the problem. One was, for instance, the background noise. Would the patient be able to put on the headsets themselves, and so on? Can they actually do it, and can they cooperate to the test? So we designed a randomized controlled trial where we made we took in 250 patients, and all of these 250 patients, they were measured twice. They did one measurement with the user-operated audiometry, and another measurement was done in a completely normal, standard, traditional way. The order of the measurements were also counterbalanced, and so the patients did not really know which audiogram was actually used for fitting their hearing aid. So we made a draw after they have done both tests, which audiogram to use for hearing aid fitting, and then we took the audiogram and we fitted the hearing aids, and then we followed them up with some testing afterwards. For instance, free field speech tests with hint, for instance, and we use some self-reported questionnaires like the SSQ. This is just to show the setup here. So we actually have the randomization is done here after the two initial tests, so the traditional audiometry and the user operated audiometry, and they also answered some basic questionnaires at the baseline here, and then we did the randomization and then the hearing aid fitting, and then we followed it up with the questionnaires and the testing afterwards. And we designed it as a what we call a non-inferiority trial, and this means that we would not allow the audiogram, or sorry, the fitting based on the audiograms from the user-operated audiometry to be inferior to the fittings based on traditional audiometry. So we look very much at the outcome with the hearing aids after using the clinical test. So the audiogram is still the most important examination that we need to use for fitting a hearing aid. It may be, as Lene pointed out in the last talk, that there can be done something additional, and it may be even possible maybe to estimate an audiogram from other tests in the future. That could be really interesting. So, but so far we still need the audiogram. All our participants were first-time hearing aid users. I should said that. This one I already mentioned. So we did a lot of outcome measures. I already spoke a bit about that. So we'll here focus mostly on SSQ and the hint test. And we also used the IOA, HA, and the AFAB questionnaire. So with the effectiveness of the hearing aid fittings based on the user-operated audiogram, will that be non-inferior to the fittings based on audiograms from traditional manual audiometry? That was our question. And yes, we actually found an identical improvement in speech perception using no matter which method that we actually used to fit the audiograms from. And we also figured out that the more than 90% of the patients, they are they have no problems in operating the tests. So that's also a very nice finding to have. And I would say that the number is even higher, but there were some cases in between that need to have some re-instructions to the test, and even in these cases they were also able to complete the test perfectly without any problems. And we have another finding that is interesting here. It may also, the user-operated audiometry may actually also improve the quality of the test, the audiometry test conducted in the ENT clinics. I will come a little bit back to that in a moment. Just looking at the primary outcome here, which was the SSQ 12 questionnaire, where we found an improvement around, I think, around 1.6 as far as I remember, and it was the same basically in the control group and the user-operated audiometry group here. So no difference between the two groups in the change of SSQ, and the effect size of 1.6 around SSQ is very similar to what we have found in other studies. For instance, the bear study that has also been mentioned here, it was more or less the same effect size that we found in that study. So this is about the change that you could expect from an SSQ 12 questionnaire. And as we also said, this has also become the questionnaire to use for following up effect of hearing aids in the Danish system. Just started this year that everybody will have to do the SSQ 12 questionnaire as a monitoring for effectiveness from hearing aids. And here this is just some statistics showing that we do not have a significant difference between the groups, and this is what is important here. And later on we also did the same for the hint test, and in general we got the same signal to noise ratio in both groups. So no difference of between whether the hearing aids were fitted using the traditional autograms or the user-operated autograms here. And this one is the study that we did where we actually compared autograms from the ENTs with the user-operated autograms and even the manual, the traditional autograms. Here we have called it non-audiologists here because as from my first slide you could see that some patients also go to the ENT doctors to have their autograms measured. But what we also realized is that those clinicians who are conducting audiometry at the ENTs, they have many different backgrounds. Some would be secretaries, some would be nurses that have been taught to how to conduct an audiometry. And these are the two situations where we have one of the best and the worst agreements that we could see here. But in general, what you can see here is that in general they are a little bit, the difference is positive, meaning that usually the threshold measured at the ENTs will be higher compared to what we measure with what we measure with the traditional audiometry. And here you can see it's up to almost 10 dB here at 1 kilohertz. But when you look at compare user-operated audiometry with traditional audiometry, the difference is almost null. So that's one aspect of looking at it, that we get closer agreement between the user-operated autograms and a gold standard audiometry made in a booth in a hearing clinic. You can also see that's a larger variation here of the dots here, meaning also that the variability is larger. So this is also one reason why it may not be appealing to fit hearing aids based on those audograms that actually have been recorded at an ENT clinic. And the purpose of doing an audiogram at the ENT clinic would be more of a diagnostic purpose, where our purpose is also to have a reliable audiometry that we actually can use to fit hearing aids. So we are now looking into what can we do if we want to implement this user-operated audiometry. We could put it in the ENT doctor, which will raise the quality. We could also use it at the public hearing clinic, and maybe even the private hearing clinics could use it as well to increase capacity. We will have the audiograms made somewhere else, maybe outside the system. And we are also working on a system now to put it in the cloud, the audiogram, so that actually you could use the audiograms no matter where you are, because the audiogram if it has been conducted in a reliable way, then you could probably use that audiogram to fit hearing aids, and this would be a really step forward, and we could avoid repeated testing, and maybe this will also give a nicer flow for the patients and a faster track to get the hearing aids, and we may even save some money on this in the long term. So I think I will end my talk here, and just put the attention to some of the collaborators that have been involved in this work in this user operated audiometry project. Thank you.
Thank you very much, Jesper, for your presentation. Now you can unshare your screen, and I
do that here.
will. Yes. Now I will leave the word to you, Dorte, to take the discussion from here. So take it away.
Thank you. I also want to thank you for the opportunity to participate in this webinar and moderate the discussions. And I want to thank you all for the excellent presentations. Very informative and learning experience. We had already the first questions during your presentation, Henrik, and I think I would suggest that all four of you consider a response to this, because Martin Sørnes asked, what do you see as the biggest gap today between what patients actually struggle with and what we routinely measure in the clinic? And I suppose you can decide yourself whether you think the biggest gap is in the referral stage or whether it's in the fitting stage, the objective measurements that we use for the fitting of the hearing aid. But first, Henrik, what do you see to be the biggest gap between what patients struggle with?
Thank you for the opportunity to answer this question. I think that one of the biggest challenges is complex pathways. It's very confusing, and there are, in the current pathways, a lot of examinations that are repeated. Not just the audiotomy, the hearing measurement, but also the questions and even the visualization of the ear and the eardrum. I think that we need to consider to cut away some of those examinations.
Right, that's sort of the systemic answer to the hearing system. As I understand the question, the biggest gap today between what patients actually struggle with and what we measure in the clinic, I think it's probably more on the diagnostics and the hearing tests and whether it adequately reflects the problem that the patients have. And I fully acknowledge that the confusing system is no doubt a big problem. But I think this is more specific to the diagnostics we can move it on. Lena and Jesper had the presentations that went more directly into the direct measures. So, Lene, what would you consider to be the biggest gap in what we measure in the clinic and what people struggle with?
So that was directed to me. I'm so sorry. I cannot really distinguish the Lene and Lena.
Sorry about that.
That's totally fine. Well, I think it really reflects a very general point. So in the clinics as well as in research, we usually try to find reproducible and reliable and more or less accurate measures that more or less characterize hearing, but it's not necessarily characterizing hearing in real life. So you always have a trade-off of control, which means accurate, reliable measurements, and less control, less accurate, but ecologically more valid measurements. And I think that is really a general problem that we are facing here. And I mean, as I said earlier, I think a more multidimensional set of parameter measured can maybe get us closer there, but I think I cannot like point out this is the largest gap, but I really think that's a general problem. And yeah, maybe we have to think about measurements in real life situations to be able to, first of all, pinpoint the most problematic situations, because that can be quite different between people as well. So yeah, I'm sorry, that's probably not a satisfying answer, but I still think this is not an easy one either. So yeah.
No, I completely agree. It's one of the most difficult questions. Jesper, what do you see to be the biggest gap between what patients actually struggle with and what we routinely measure in the clinic?
Yes, I think going directly into the measurements, of course, what we often focus a lot on in the clinics is measuring the audiogram, and it's because we need the hearing thresholds for fitting the hearing aids. That being said, also it is also a problem at the same time, because we do not know. We know the level of where the patient can hear, but we do not know if they actually understand what they hear. But for that reason, we also have these speech audiometry tests that can be used. But these will of course reflect hearing. And in most clinics in Denmark, these are measured in quiet, and this may not be the optimal situation, because most people face challenges in noise. So actually, a hearing in noise test would probably be better. The problem is that we still cannot use these results from a hearing in noise test to fit hearing aids. So we still only need the audiogram basically to fit hearing aids correctly, at least according to the knowledge that we have today. So we somehow need to figure out how to use all these different types of tests. Lena has also pointed out some of those tests that may be useful in the future. How to actually get use of those tests also to fit hearing aids differently in order to meet the needs from the patients, and to meet the challenges that the patients actually will face in real day life. I don't think we are there yet, but there might be some tests coming out that could be useful. One is, if you have heard about this auditory contrast threshold test, it is maybe a test that might be useful also to direct the fitting of the hearing aids, so that it's not only dependent on the audiogram. But I think that we need to get somewhere there and do other measures and get to use other measures in order to fit hearing aids more individually than we do today. It was a long answer, but I hope it was somehow encapsulating the...
We actually have one more question that goes very deeply into the specific test. And I should say, because I can see that we have a participant that have shared a link to an article. Please share that in the ordinary chat. It's the Q&A chat is not for sharing material. You can use that you can share that in the ordinary chat, please. But the question is, when it comes to speech in noise testing, how do you view the clinical relevance of a 50% correct threshold compared with a 70% threshold? Do you think one of them provides a more meaningful picture of everyday communication ability, and is there a need for a stronger standardization in this area? I might even add, might there be a more satisfying patient experience in participating in a test with a 70% threshold rather than the 50%? And I think this question was asked when Lena gave a presentation, so perhaps you would go first with an answer.
Yeah, I think so. I mean, the 50% thing is done in labs and research a lot because it's you can calculate that very accurately and very reliably. It's like the steepest point of this discrimination function. So I think that's why it's very popular in research. And of course, I hope most people do not have to communicate at 50% speech intelligibility situations in real life too much. So, because it obviously does not reflect real life speech communication to a great extent, and there 70% is probably really the better choice. However, well, probably you know, but so from the adaptive measurements, you can calculate either one. So yeah, so you can probably discuss all day long if like the sentence test is the better choice or something else, and it also depends on what people are used to use and so on. But yeah, I think in terms of clinical relevance, 70% is probably a good one, and in research we like our 50% threshold.
Thank you. And do Henrik, Lene, or Jesper have anything to add to that? Jesper?
I actually have experience by doing both using the 50% and the 70%, and they are. I agree with you, Lena. The appealing thing about using the 70% is that you probably it's probably more motivating for the patients to because they have more they have more words that they understand. On the other hand, if you're working with the patients with severe hearing loss, you actually get to a problem where they have difficulties achieving a 70% correct score. So that's also that can also be a problem. I've worked with that in a cochlear implant users, and I must say that's very challenging for a majority of the patients even to reach 70%. So that means that they really can't reach the signal to noise ratio. It will basically be a test in quiet because the noise has to be so low. Even in quiet, they have difficulties achieving a 70% correct response. So that could be one. That could be one challenge of using this test. So I think people should also think about the purpose of the test. So I'm a little bit in between whether to use 50% or 70% because I agree with Lena that we have the most steepest point on the psychometric function. So that's probably why people go for 50% because of less variability around that point. So
thank you.
Yeah.
And this is a sort of a very classical discussion whether to measure the irrelevant thing very accurately or the relevant thing inaccurately,
Exactly, yeah.
and it's always hard to know. So I'm going to move on to a question of slightly more systemic nature. So this is Mark McHugh asking, Audiology and ENT software like AuditBase has historically been a system of record, and to evolve further into a system providing greater intelligence that truly drives clinical decisions and adds value for clinicians and patients, which would you prioritize? Would it be AI or would it be workflow redesign? Would it be real-time insights and reporting needs, or a deeper integration with devices and hospital systems? So Henrik and Lena, is that?
So yeah, I
So
can say something about it, and Lena
yeah,
is about to move over here next to me. But well, we can start with that. We have been looking on the pathways. So
yeah,
that's what we thought were a way to start. But I'm not sure that it's limited to that, and I don't think that it should be. I think that we should actually work on all the things that are listed here at the same time, because one of our main goal is that if we do something new, it should be tested in a scientific way, so it's patient safe. And it would be very hard to do all that at the same time. If you do it in one workflow, you have to test every segment for itself. And I think we should work on everything at the same time. At the moment, we are working on pathways because that has something to do with a strategical perspective. There's a lot of politics involved and authorities, and that is a big ship to steer.
yeah. Thank you.
I can
Lene?
add to that that the things that we're working on is not completely isolated in silos, like Henrik says. An AI decision support tool as a build up next to in here, the next future step could be an AI or an automated decision support tool. But we also need to know to look at how are we using our data? Are the data packages, are the pathways that we have designed, are those really the pathways for the future? Do we really need all the data for all patients at all times, or could we actually exclude some of the data for some of the less severe cases so that we optimize on our workflow design, but at the same time think in AI possibilities or solutions to think about how to integrate those thoughts. It's not isolated silos, but they do actually come together in the diagnostic workflow organizational thought.
Yeah, thank you. And Jesper and Lena, do you have anything to add to this?
Yes, I think I have also looked into to using a large you could say large data set of autograms and how we actually can use that. So I think by using AI to also predict the diagnosis, for instance, from the autogram could be very useful. And as Lene pointed out, having a decision tool somehow to support the clinicians. Autogram use in the clinic it's very much a pattern recognition of specific phenotypes of how the autograms look like, and you use that to interpret maybe the cause of the hearing loss. If you're just looking at fitting in hearing aid, this may not be that important because you do not really differentiate between whether this is a noise-induced hearing loss, or an inherited hearing loss, and an age-related hearing loss. But it could give you some ideas of the prognosis. How will the hearing change over time? This could be important for clinical purposes and so on. And I think if we have a large amount of data that we actually can use to give such suggestions on an individual basis, I think we can achieve much more within audiology for the future. So I think that's a really this could be a really big step forward there if we can use the data even better.
Thank you.
Yeah, maybe if I can add like one or two sentences. So I totally agree, and I think that so we have been thinking about an approach that we sometimes call hierarchical auditory phenotyping. So really the idea of starting off with some rather standard basic measurements and then deciding if you need more information or not. So then going deeper into the phenotyping, so to say. So we are not really there yet, but that is obviously reflecting the problem that, you cannot measure people like over and over again and letting them do tests and spending hours and hours on testing. So I think this approach to, and this is kind of a profiling approach too, to differentiate between, so is this something very, very common, or like Lena, what you said, like complicated or uncomplicated is probably the first decision to make. And I think that's really the way to go. So by reflecting limited resources and kind of collecting as much data as you need, but also as less as you can deal with. So that's probably something that we want to aim at. Yeah, and obviously we need data on the broader range, and to get an idea of the distribution of different characteristics, and maybe also taking into account data on health conditions beyond hearing that might be connected. So I mean, that's really we are not there yet, but I think that's also a direction we should consider to go.
Thank you. So I'll move on to the next question, because I think it's actually very important both today. And this is from Mark, who's asking, how will the role of the audiologist or the ENT specialist change if remote triage and self-testing become mainstream? What skills do you see clinicians need in the next 5 years that they don't necessarily need today? And I think that's an excellent question, because, and I cannot help think about your presentations, Lene, on where you see the higher accuracy in the digital visitation, because that could be indicative of a difference in skill sets already. And maybe that is a problem that can get solved with the more remote and digital tools, supporting tools. So who want to go first? Henrik and Lene, perhaps?
Lene, perhaps?
Yes, I think you're right. I think it's a very good question, because what we did in the In-Here project, we were rearranging and redefining the tasks and setting some standardized criteria for how to perform those tasks. And I think that partly helped the digital referral group having that higher accuracy. There were very specific, there were data quality criteria, and there were tasks that were very well defined. That in itself will be something new to redefine what we already know for the assignments and the tasks that we do in the patient journey. It may not be that we're giving ourselves new competencies, but we're maybe going to rearrange to whom they are assigned to and how well we want them to be performed. I think that's a good question for the future, and for us to look at how are we going to rearrange that those tasks so that it becomes the better of the patient. And maybe it will even save the ENT. You will have to like go in the background and not be in the front step of the journey, because we will have the audiologist performing the initial standardized tests. The doctor or the ENT will actually retreat to a later path, make more a quality verifying, evaluating task, and also freeing time for other patients simply. Maybe we don't need the ENT as much involved in some of the more less severe cases that we're used to today. That's also very controversial to say, but that could also be something to think about in the future.
Yeah, thank you. And Jesper and Lena, anything to add?
Yeah, I can follow a little bit in the line as Lene said, from the ENT perspective. It may not be needed, or at least it's probably not very beneficiary for the society that the ENT should see every single patient with a suspected hearing loss. It might be that they should see a part of them, depending on what the initial examination will show. So of course, it will also put on more work, and you could also say more responsibility for the audiologist that is actually maybe doing the initial examination, because they will have to judge whether this patients need to be seen by an ENT probably parallel to the treatment that is being conducted, for instance, with the further hearing aid treatment. So they would be needed to judge whether there is actually also some a surgical middle ear problem that could be handled, or even if there is an asymmetry of the hearing loss that should where some further examinations like an MRI scan should be conducted and out to rule out an anal tumor. So that's that I think that's where I could see this could change. I also see if you use more self-administrated tests from the audiologist point of view, then they would probably spend less time on doing the tests, as I also pointed out, and maybe they could use more time on fitting hearing aids and even counseling patients, which is also a very important part of getting satisfied patients to use the hearing aid. So I see more like a system where we have to move certain tasks from one group, for instance, ENT to audiologists, and then let the ENTs focus on what we really need them to do. To be honest, it's very few patients who actually have pathologies in the middle ears and eardrums, and you would be able anyway to spot these on an audiogram, looking at the audiogram. So if when you see, for instance, a conductive component in the audiogram, this could be something in the middle ear, and that's of course a case that the ENT should see. So that's also where the digital system, as Lene pointed out, can be very valuable to screen those patients in order to figure out who will benefit to be seen by an ENT and who will not. And so we can actually get a faster patients in a faster flow of getting the hearing aid sooner.
Thank you. And then we have a very tricky question here by Raoul. It's specifically for Lena, but I think we'll take it generally also. The final goal to fit hearing aids better, have you thought of presenting some tests through the hearing devices directly? And the comment also suggests that the technology already exists for some hearing aids. So that's where I would like also a general reflection on the system or the situation where we actually might have technological devices that can do tests in situ or remote, or whenever the patient sort of have time to interact with the device and reflect on hearing ability and whether the problems have been solved with the given device. And then that information currently not being available to the practitioners in the clinic, or at least not in a standardized way. So Lena, please, what are your reflections on this?
Yeah, we have thought about aided measurements in general, because that's of course a very interesting point, especially comparing aided and unaided measurements and so on. We are not specifically working on doing that so far, but what we are working on is integrating hearing aid signal processing. So we have this so-called open master hearing aid, which can apply hearing aid functions to the signal. But so far, we are not working on directly streaming the signals and so testing via hearing aids. I know that for CIs, there is work on doing that. Tobias Göring in Zurich has been developing a platform where they stream signals to CIs via Bluetooth. So yeah, it's definitely a direction to follow, and it would be very interesting to get that data. But we are currently not working on the streaming issues, as we have. Well, the experience is that if you, well, the hardware problems, and so there are several obstacles in really making that work. And but it's of course a great idea. And so there was a follow-up. I'm sorry.
No, but thank you.
Okay.
Sorry, I was just reading a little bit further. I think the follow-up was that it's already embedded in some of the hearing devices.
Yeah. And I mean, of course, it also is connected to this idea of self-adjustment and the idea of, kind of putting people in the position to kind of fiddle around with the settings and getting closer to the personal preference of settings. So, yeah.
Right. Thank you. Any other with any?
Just a short comment. It is of course also there's also a need to figure out how the clinicians can benefit of such remote checks. I have a little bit experience with it in the CI system, as you mentioned, Lena. But still from a clinical point of view, and also in relation to what is required of capacity for clinicians, you probably still need some interaction with a clinician in order to understand how to use those tests. If it can be completely independent and you can use tests, and the hearing aid may even use the tests to do some adjustments, then we are getting to a point where I think this could be really interesting, because it means that the patients would probably not need so many adjustments anymore if they are able to figure out some of this themselves. I think I'm not quite sure we are there yet, but probably we're getting there.
Thank you. We are coming to an end, and we have a couple of questions which are actually a little bit out of range of the current theme for today, but I think I'll just offer a few quick questions or quick responses to that as well. Ask is asking whether there are plans to revise the danger threshold of 85 dBA per workday. Recent research suggests 75 dB might be the real safe level. I would suggest that you consult the World Health Organization reports. They are moving from these 85 or 80 dB average per workday into some 7-day a week, 24-hour averages of 72 dB, which corresponds actually to the same exposure level. And they are also dealing with the different levels in Pascalian hours, 1.6 Pascalian hours and 0.51 Pascalian hours, which corresponds to the 80 dB over 8-hour average and the 75 dB over 8-hour average. And we don't currently know exactly where to put the risk criteria for hearing aids treatment. There are obviously some pathologies where you need to have a high amplification, and where you cannot enforce the same sort of damage criteria that we have for healthy populations. Then we have another question, whether there is a currently available tool that allows a quick, reliable self-screening. The target would be evaluating noise exposure and fatigue in a simple way. And a rough test is also delivered by the World Health Organization. You can find the app. It's the digits in noise test, where you sort of adjust the level yourself. So this is a very crude approximation of the more advanced test that Lena presented with the sentence test. And this digit and noise test can give you sort of a very rough idea whether you have normal hearing or not. And it was developed exactly for that purpose. Right, I think we have more or less come around the question that were asked during the presentations. Do any of you have anything that you think should be added before we are ending the seminar?
Well, maybe I can strengthen 2 points. So I think what Jesper said is really important, that talking to the patients really makes a significant influence on the outcome. So management of expectations. So what is achievable? What has to be done by patients, of course, with implant hearing aids. So, and kind of getting time for that by sourcing out some of the measurements, for example. So that could be done by audiologists, this consultation. I think that's really something that should be kept in mind, and not just make everything faster and faster again, but use the time that is that you gain for this consultation. And also, I would really strengthen the point that I really think we need to more think in terms of combining data from different sources, institutes, because there is so much data, but it's all so spread out, and that's why people measure so much. And that would really be a great opportunity. If we simply could use all the data that is there, we would really make a great advance, I think. And I just wanted to point that out. But yeah, thank you for this great event today.
Thank you. And I think I might. Oh, okay, sorry.
Yes, I was just saying, is there anything left to add? Otherwise, I will wrap up the webinar.
Well, maybe a small comment on the triage, because I think it's very common terminology to talk about the complicated and uncomplicated hearing losses. And we very rarely talk about the complicated and uncomplicated patients, but motivation and leveling expectation is very much a part of navigating that space, because some patients simply are harder to please, and they might also have cognitive challenges and many other things. So that might be something to also keep in mind and reflect on, whether there might be something which isn't buried directly in the clinical measures and the assessments, whether we can level better with the patients that we have and not the ones that we wish we had. So sorry about that, Jeppe.
That's okay, and it looks like Henrik and Lene wants to add a final thought.
Well, that's just something that we didn't mention under our presentation, but a part of the digital visitation or assessment is also that we create a national hearing file where we can store all the data. And that's quite an important point that you also said, Lena. Let's try to gather all the data as much as we can to even underbuild a good quality even more. And that would also give access for all participants in the pathway to access these tests.
Thank you very much. And with that, I would like to say a big thank you to all of you for being in the panel today and sharing all your expertise and insights. I'm sure that people in the audience came away with a lot of great new knowledge here. So thank you very much for that. And I believe I had the wrong graphic for you, Henrik and Lene, in the initial presentation. Very sorry about that. But if you are interested in this area, please join our next webinar about a new Danish sentence test. It's the April 9th at 10 o'clock. And we have a great panel there as well. And we also have a webinar coming up about Oracast, which has been implemented at Frankfurt Airport, and should be very interesting as well. And I encourage you all to visit our website for all kinds of events like this one, webinars, network events, seminars, and other great stuff. And you can follow us on LinkedIn, Instagram, and this webinar will be out on YouTube shortly, where you can watch the whole thing and you can share with your colleagues and friends in the sound field. So with that being said, I would just like to say thank you to all of you once again, and hope to see you some other time.